All right, welcome everybody to Blue Sky Matters, where we mind what matters. I'm your host, Dr. Anthony Harrington, and I'm glad you're with us. We're a brand new show, so if you could hit the like and subscribe buttons, it would really help us out. Our goal is to bring education and camaraderie straight from the experts in blue sky and in neurology by providing reviews of the latest science and protocols while having thoughtful discussions about the challenges that faced each and every day. I myself and our guests are part of Carepoint Blue Sky Neurosciences, your one-stop shop for anything inpatient neurology. We're talking neurohospitalists, we're talking stroke, telestroke, EEG, program building, and everything in between. If you're interested in learning more about Blue Sky or joining our team, please visit our website at blueskyneurology.com. And I have here Dr. Jeff Wagner. Thank you for coming on. How are you doing today, sir?
Doing well. Thanks for inviting me.
Absolutely. So let's just start off. When did you get started with Blue Sky Neurology?
About 17 years ago in 2009 is when I joined. And at that time, we were just in Denver, one location. We were already doing telemedicine, which was pretty early for that. But I was the fourth doctor in the group at that point.
Wow. Um, yeah, starting Telly so early, what was that like trying to get that off the ground and getting people like, sold on the idea?
Well, I have to say that I walked into it because Fanal was really on the cutting edge of telemedicine, and I will say that. I know that he used a tobacco grant to get funding to get this thing started, and it was extremely successful. He got a lot of awards for doing that. And then the technology was the biggest barrier back then, as you might imagine. Internet
Yeah,
was not as reliable. And so, yeah, I mean, first you have to tell a place that they need it
yeah,
and convince them they need it. Then you get the technology in there, and then you pray that it works well enough that they don't stop calling you. So now it's a lot easier because once you get stuff set up, it's pretty foolproof for the most part.
right on. Did you have to use any dial-up or was it past that?
Oh,
I'm just
yeah, I mean
kidding.
that was still that. I mean, yeah, right. The AOL.
Yeah.
No, there were probably people using that.
Yeah, that. So what has made you stick around all this time?
Um, I I just I got lucky and found my home at Blue Sky. I basically knocked on the door and asked if they needed help when I moved to Denver because my wife's a physician. She had asked around. They said, you know, university is probably not where you want to be. You probably want to be with Blue Sky. They're the cutting edge in Denver, and so it turned out to be true. And it's been a fun ride. I mean, we started with one hospital, and within 5 years or so of me being there, I think we were up to 10 hospitals. And so it's just been growing you know, new places to work, new environments, new opportunities. And, of course, a lot more to the story than that now.
Yeah, and since that time, Blue Sky has gone from Denver to Kansas City, where I'm at, and multiple other cities kind of across the country, both on the tele side and the in-person side. During this time, you've held multiple leadership positions. What is a piece of advice you could give to someone starting out in a leadership role?
I would say that probably the first thing is to try to get a warm handoff from whoever had the position before and figure out who your key people are, your key supporters, and make sure you value those people. That'd be my first piece of advice is realizing that you're not probably going to be the most important person, even though you're
Yeah,
director.
for sure. Yeah, I've definitely noticed that our stroke coordinators are probably our more important, do a lot more of the actual work sometimes.
Definitely.
Um, so since entering practice, what has been the biggest surprise for you when it comes to the advancement of stroke care?
I think it's that it's such a team sport. I mean, no one person can make a stroke program work. No five people can make a stroke program work. I mean, the most important ingredient is an aggressive group of vascular neurologists who are going to
Yeah.
drive the process and respond at all hours very quickly. And so, you've got to have that. But I think that you have to have a supportive ER, supportive EMS, supportive hospital for pharmacy services, nursing support, all the things you need to work perfectly every time to make sure you're doing a consistently excellent job.
Yeah, that makes sense to me. Okay, so getting to the topic at hand, you've joined us today to talk about a topic that still seems to be finding its way throughout the, neurology and stroke world. That's MeVO, which is medium vessel occlusion. This is related to acute ischemic strokes that have an occlusion in the medium-sized vessels, so a little bit further out than typical thrombectomy targets. And to see if these are truly benefited by mechanical thrombectomy. So to start, how would you define MeVO?
So that is one of the tough things is that there's different definitions in different trials. And so if you look at the main trials that have been done on MeVO, there's been four main ones so far that are published and talked about. It's not even agreed upon within those trials. So for the most part, I think MeVO means M2 occlusions, ACA occlusions, PCA occlusions, not including M1 of the MCA, terminal ICA, or basilar artery occlusion.
Okay. How are these typically managed in real life situations now before, these new trials and everything came out?
So it's been interesting to watch this. In Denver, we have a very aggressive group that's been working together for 20 years or so, even before I came. And so we all are pretty much on the same page about, somebody comes in with an important deficit related to an acute stroke, we're going to try to treat it. It doesn't even really matter where the occlusion is. If there's an occlusion they think they can safely get to, they're going to go and get it. And so unless we tell them they shouldn't.
Right.
And so that's a really nice situation for us as neurologists to work in because so supportive. So I guess it's been more aggressive here than most places for most of my career. I would say that. And so after the landmark trials, Mr. Clean, Escape, all the other ones, they're all
Hmm.
excellent trials, not to name uh, all of them, but uh, they did analysis subsequently called Hermes database, compiling all those things. And they actually looked at M2 occlusions specifically because those were included in many of these landmark trials. And they showed that there was great benefit for recanalization of M2 occlusions in in this group of patients. And so at that point, which was kind of late 20 teens,
Yeah.
uh, really it was standard of care to treat at least M2 occlusions and at least the dominant proximal ones. And nobody really knew how far out you should go. You just
Right.
knew that was beneficial. The hard part has been like, yeah, so much variability.
Right. Yeah. And, it could be operator dependent, it could be patient dependent, all those things. Yeah. Like through my training and early in the career, we've just kind of gone after all the M2s if there's significant deficit as well. So, but now there's specific trials that are looking at the outcomes with M2s, and not to put you on the spot, but like, can you tell us a little bit or like what are those trials called?
Yeah.
What are they looking at?
Yeah, I think it's important to know these because and the timing of when they were published or announced. So the first thing was 2 years ago at the AHA, American Heart Association Stroke Conference. Escape MeVO and Distal trials were released, and so these two trials used, you know, there's been tons of criticism and for good reason. They allowed mild strokes with MeVOs, but they were supposed to test MeVOs to see, and the trial leads felt that there would be obvious benefit from treating MeVOs. You talk to them after the fact. The problem is they allowed people with mild strokes to be included, and so even down to like an NH of 5 was
Yeah.
enrollable in these initial trials. And so unfortunately, and the sponsors of the trials both, kind of regret doing it this way, but they didn't show benefit. And the main problem in the end was that all the really severe MeVOs got taken out and treated outside the trial. That was allowed. And then all the mild MeVOs got treated within the trial, and there wasn't enough deficit to prove a benefit in those
Right.
patients. So another unfortunate thing is that the updated stroke guidelines got published using these trials as the primary data source for whether MeVO should be treated and resulted in a recommendation against treating MeVOs.
Yeah.
And so that doesn't make sense to me. And I think
Right.
most people who treat a lot of stroke are bothered by that. Um, right after these guidelines were published was the next stroke conference. And so
Hmm.
at the new stroke conference, they announced two new trials that have been done, Oriental MeVO and Distols. So the first two trials are Distol. Now there's a Distols for,
Gotcha.
I wish they could have found a different name, but these two trials both showed really promising evidence for treating MeVos. So the Distals trial actually just was a proof of concept trial using a different device that's designed to treat the small vessels, and nobody had a complication when they used that device.
Yeah.
Basically, that's all they were trying to show. Oriental MeVO actually treated people with worse strokes, like higher required stroke scale with a MeVO, and showed benefit. And then if they took a subgroup analysis of all their patients enrolled, if they had an NIH of less than 8, they didn't benefit. And those were
Yeah.
the most patients that were in the prior trial. So it all seems like it is going to make sense in the end that, we really should be treating MeVos with important deficits.
Yeah. I mean, so the NIH seems to make a kind of huge factor. What is there like a threshold that you use, like a particular score?
Um, I, I mean, based on the Oriental MeVO, I'm kind of tempted to use 8 as a
Yeah.
rough cutoff, but I think there's different eights, depending on whether the eight's from aphasia or the eight's
Hmm.
from other things. And so, I think we still, at least in Denver, and in our main place we practice is Swedish, and it's been the same the whole time I've been here. It's
Yeah.
how bad is the patient disabled by this deficit for their life? Like, what does it mean for them, as best we can tell? And if it's
Right.
important, then it doesn't matter what the occlusion is or the NIH is. We try to help.
Right. Yeah. And I agree. Like, the NIH stroke scale is great. It's been kind of like the gold standard for like all these trials since the 90s, right? But, it's not weighted for every type of stroke. I would argue that aphasia is way more disabling than other things that get scored on there. So, there's not like a weighted scale based on disability, unfortunately. Um, yeah. So just to recap the timeline, it sounds like, most people have been going after at least M2s or these medium vessel occlusions in order to get, you know, an improvement in functional outcome. And then we had a couple trials to try and prove that concept. And, maybe we included maybe too many people, regardless of their deficits. And then we had the guidelines come out based on those that didn't really recommend for and possibly against them. And now we have a couple more specific data for these population, more trials that have come out to show improvement. Is that right?
That's right. I think the people are starting to realize that a blanket statement against treating MeVos is
Yeah.
is probably not what it should be.
Yeah, it's interesting how these trials keep happening. Like the ones in 2013 before the landmark ones in 2015, like we all thought this was going to work because it makes sense conceptually, right? Like there is a clot blocking the vessel. So if we pull the clot out and restore flow, you should get better. But the first trials weren't showing that until we found one and we modified the techniques and the devices enough to actually prove that. So it seems like that's happening a little bit more distal to those proximal vessels as well.
It is really really reminiscent of that.
So we kind of talked about your personal rule of thumb. You said NIH of 8. Is there anything else that you typically kind of like, does perfusion kind of come into it at all for these medium vessel occlusions?
I think first of all, it seems like sometimes perfusion is what helps you to find them.
Yeah,
That you
true.
see this big wedge, and then you go back and look at the scans, and then there's a vessel occlusion, and it's really discussion with your interventionalist to say, is this vessel accessible? Do you think it's more risky than usual? Is there any concern you have about treating it? Because it seems like the patient's got a bad enough problem to try to help. And
Yeah,
so, I always try to do IV thrombolytics as well in these cases, of course, do standard of care, and we've got extended window and other things that give us more opportunity. But yeah, when it comes to a large vessel occlusion, you know, we try to go based on severity and whether the proceduralist feels that it's not undue risk to take on.
right. Do you think eventually we're going to make even smaller and smaller devices to get further and further out? Like, where do you think the risk will for sure outweigh the benefit? Like, how far out do we need
Gosh,
to go?
I don't know, but I will say that, you know, Don Fry is the guy that I've worked with for the longest here, and
Yeah,
he's great. I mean, everybody knows him pretty much. If you do stroke, you know Don Fry, but he he's pulled M4s out
wow,
before, for somebody with severe expressive aphasia, and it's worked.
yeah,
And so that's proof of concept. It doesn't mean that it would work every time, and it probably is more risky than some
yeah.
other places. But I think I think they're going to definitely be able to make devices to make it safer.
And if we can't reach it, what about using intra-arterial TNK or TPA? Like if we can't reach it, putting some thrombolytic on there. Do you use that in real life practice in everyday scenarios?
We used to use it when the devices weren't good enough. And so, what I remember from that time back, more in the early 2010 time period is being disappointed. It didn't work very often for us. However, that doesn't mean it can't work. And
Right.
it is, I'm sure better than nothing in most cases is, if you can't get there safely with a device, if you can put some TNK on it, that's probably going to, I mean, seems like the right thing to consider doing. I think there's some trials that are showing that, after thrombectomy, you squirt a little bit of TNK in that vessel to make sure all the distal stuff is being dissolved as well. That's still kind of being debated, and we're not doing that yet here.
Yeah.
But I think it makes sense. The concept is good.
Great. Well, thank you. I mean, is there anything else you would add to the discussion of MeVO, at least in its current state?
Um, I I think that I'm just excited to see more trials. I hope that people are brave enough to include people with severe deficits so that we can undo the recommendations, hopefully, and allow treatment for people who have really important problems with things that we can really help with, I think.
Yeah. All right. Well, thank you, Dr. Jeff Wagner, for joining us today. And to all of you at home, again, please like and subscribe to be notified when new episodes are recorded. If you're interested in learning more, visit our website at blueskyneurology.com. If you got questions or you have topics that you'd like to see covered or just general feedback, please email us at blueskymatterspod@gmail.com. Blueskymatterspod@gmail.com. Thanks, everyone, and we'll see you next time.
Thank you.